Good afternoon. I'm Dr. Birney. So I'm here to present a case for you, a young 25-year-old, otherwise healthy male. He initially presented with complaints of vague abdominal pain, and during the course of his workup, he was found to have gross hematuria as well. He underwent a CT scan initially that showed the findings that we'll see on the next slide in just a moment, and was referred to Dr. Rastinehad in consultation. We subsequently got an MRA, which I'll also show you in oncoming slides. So why don't we go ahead and go to the next slide now. So this is images from the CT that was done. You can see arising from the right renal artery, it looks like there's a right renal AVM with large aneurysmal dilation of the draining the outflow vein from the lower pole of the kidney. We can go ahead and go to the next slide. So these are coronal images from an MRA that was performed. We start off and you follow that right renal artery all the way out there. And we'll catch it again on this next one. As it goes into the lower pole, you see a coil of vessels down there. It looks like that's the nidus. So we're selecting that artery at the moment. And on the run that we had just performed a moment ago, we saw the outflow into the venous system. So our plan is to go forward with coil embolization of this to block up the fistula.
We have a couple different things that we're doing here. This is a 6 French slender, so it allows us to put in a 6 French guide. The first thing we did, if you could, we'll play the run in a second, but the first thing we did was we put down a Transradial, and we did a angiogram. Let's show the first run we did. And we were thinking we might do an aortogram, but we have such good pre-procedure imaging that we just popped right into the renal with the Sarah, and you can see how this really depicts the problem very, very well. And so at that point, since we don't really know exactly how we're going to embolize this yet, we switched out over a Benson wire for this concierge guide catheter. This is a 6 French renal double curve. So if you show you can see it here on the wrist. It's basically hub, but it's all the length we really need. So through that, we have a 2.8 prograde. It's a 150, so this will allow us to put in liquid embolics and different types of coils. And then we use that to cannulate that lower pole branch. And you can see based on the angiogram, it's pretty obvious that there's flow, basically a paucity of flow to the lower lobe because of the shunting or the lower pole. And so that's really what the major finding is here, plus that big venous aneurysm, or varix you would call it, bit related to the fistula, and then rapid filling of the IVC. So that's where we're at. We have a microcatheter very nicely seated into that lower pole branch, and so we're going to sort of defer to the panel as to how we should embolize this. I was thinking, at least to start, maybe to put coils in this branch and see if we can slow it down a little bit. Any thoughts on size of coil here? Can you play that last run? It also looks like there's 2 vessels that are sort of feeding this venous outflow. So if we could occlude this one first and then occlude the next one, I think we would be good.
We can always come back and treat the venous side if we have to later. And this is a congenital one. This is the second one I've seen in my career. I did not realize they were so rare when I see them every 2-3 years. But there's only approximately 200 cases of congenital AVMs in the literature, which makes this an interesting case for today.
So what we're going to do now, and I think unless anybody has a big problem with this, since we have a high flow catheter, what I'd like to use is a packing coil, which is basically like a long noodle, and we're going to push this in and see where it lands. It's fully detachable, so we don't we don't have to leave it in if we don't like it, but I think this might be a good way to sort of create some sort of scaffold for whatever we decide to do after this. So this is a 30 centimeter coil. This is a penumbra packing coil. It's sort of it's a thicker coil than what we're used to for microcoils. It's sort of in between an 018 and an 035 coil, but you see how it sort of just wedged itself there, and it looks like we can hopefully, well, that might be the venous outflow. We can push it a little bit more and see what happens. Yeah, I didn't really want to put in a liquid embolic agent. Here, just go forward on that fly.
Yeah, I wouldn't
initially, and so I think this is a good combination of sort of what we were planning.
Yeah, I mean, in a sense, I would treat this like a pulmonary AVM.
Exactly.
Where I want to be as close to in the arterial feeder, as close to the sac as possible. but making sure that I had some kind of scaffold that wasn't going to fly through the sac, whether that's, coil, or as you
right.
said, I think you said you had a 2.8, and a plug would work just as well.
Yep. We don't have to deploy this coil here, but I think we probably can, and then maybe sort of try to cannulate. We'll finish this branch and maybe try to cannulate that other branch to follow. I like that idea, actually. Do we have an MVP?
Yeah, I agree, because, at this point, you also have your coil mass there, so the likeliness of migration is extremely low.
Exactly.
And you'll have the covered portion of it to just shut everything down, and no liquid to potentially make it through your coil mass.
We have the option to use the plug. We have the option to use these bigger coils, and obviously the option to use liquid. And you can, through this catheter, you can push concerto coils as well. The only coil that I don't love to push through here is the interlock coil. You can do pushable coils. You can do Nestor coils. Although this situation, I would probably steer away from using anything that's not detachable. So the MVP plug is actually very interesting, and we'll see if this deploys the way we want it. But it looks like we have a pretty long neck here, trunk, whatever you want to call it. And so I think if we sort of sit it right at the edge of that coil mass, I think we might be able to get some stagnation of flow. And that may seal it, and then we can hit the other branch and then probably be done if all goes well. So you really want to make sure that when you use these plugs that the catheter is completely flush. You don't want it to stick inside the catheter. It looks pretty good. So we're going to pin and pull right here. We like the way this looks. It's basically almost deployed now. It should be open now. So you sort of deploy these plugs. If you want to focus on Art's hands here, you pull back the microcatheter. Now what we're going to do at the end is we're going to take the torque device and we're going to sort of twist it off, almost like an Amplatzer plug. The device is right there. We can also do a run through the guide, and we'll get a good sense of whether this is actually occlusive or not before we do that.
We're going to give it a couple twists, and it should detach and pop off right now.
See if you guys can see the fluoro.
It's still attached. Hold on.
We'll zoom in a little bit for you.
There it goes.
See how it popped off?
You
We'll do a
see it?
fluoro save. If you step off fluoro, we'll save that. So that's it. Now it's deployed. And so I think what we should do now is try to cannulate that other branch. And by the time this branch becomes completely occluded, I think we'll have a complete seal of this if we're lucky.
Wow. I don't see the second one.
So now we'll inject the guide and we'll see. It sort of just popped back. The other one was a little bit lower. It looked like it sealed very well.
Oh, there.
There's the other one. I think we'll probably do the same thing in that branch unless you guys have any other ideas. What do you think?
I think that run looks fantastic. When you go through that vessel that you've treated, I don't see any flow beyond that proximal, as it just shapes around that conical shape of the plug. I don't see anything beyond the coil pack.
So it's a little weird angle here, but we'll get down there and then we'll get that plug in. This to me looks almost exactly like a pulmonary AVM. Yeah, let's try the pod 4. So this is a little bit different. I think you guys saw this in the previous case. Yeah, the GDA. I think this will work well because it has different levels of stiffness. We'll put this in. We'll see if it sets up the same way, and then we'll put another MVP. And I think we'll probably be done after that.
Oh.
So there you go. Big venous aneurysm, but if we can sort of get the coil to sit right across that neck, I think it'll work nicely.
Aaron, just a quick question. So the result of the first one looks great. My question to you is, do you have any comments for the audience here, especially for the younger ones, if we use coil first or plug first?
Well, you can see, Marcello, when we put that first piece of coil in, it flew right into the vein. So that's fine if it's a detachable coil, but if you have a plug, and I remember a case very similar to this in a different anatomic structure, but once you get the plug through the fistula, it becomes very hard to land that exactly right, and the coil sort of gives you a lot more support to do that.
Great.
All right, fuck it.
You take the, yeah, that's good. I think this is going to allow us to sort of, you'll see when the coil comes out, it may actually come out distal first, and then we can get it to sort of coil distal to where we are. But we'll see if it,
You live?
yeah, we're good. We'll see if it works that way. I don't know. Right, so this is the 4. When you size these coils, you want to size them 1 to 1. You don't want to oversize them. That's key.
You try to float?
Yeah, float it. See if it'll go.
It's going down into that.
It's going into that aneurysm right there.
That's fine.
It's not gonna. There we go.
Yeah, that's exactly what we wanted to do. Nice coil, nice and long, perfect. A little left. So the other thing that we like about this particular, they're perfect. So that actually is exactly what we wanted to do. This is sort of almost like a packing coil. It's working like a plug. We may not even need a plug behind it. It's possible that we're done already. So is that filling through the coil mass? It looks like it is, right?
Yeah.
We don't have a lot of room. Well, we'd have about half the length from those markers, so we probably need something short.
No.
So we have 15 or 30. Probably 15.
You think you can 15? I don't want to take out that other branch if we can avoid that. Is there a secondary? Where's that coming from? That's blowing. That's coming right through.
That's probably the
I think it's
primary
passing right through
visualization.
still. We just don't. I want to save as much kidney as possible. You see that one normal branch heading laterally just above the tip of the catheter.
We might wait a second and then maybe put one more. I think maybe we'll put one more coil in and then see if that works. And then if not, then maybe we'll switch to a liquid embolic. But so far, I think this is moving along exactly the way we wanted it to. So I'm happy about it.
I'm happy as well.
After we deployed that plug, we put in 2 coils. We put in one packing and then one pod, 4, and then one packing coil on top. So in total, yeah, that's a good depiction of it. In total, we used 3 coils and 1 plug and 2 vessels. So we're going to do one final run for you guys, and then we're done. Sir, can you hold your breath? Wow.
You can breathe in a second. Breathe again, and then hold your breath for us, okay?
Okay, do it one more time. Okay, keep holding it. So we fixed it, it looks like. I mean, there still is a little bit of flow into the vein, but
You can breathe, sir.
we're pretty happy with the result. That part of the kidney, you know, it really wasn't getting much blood flow to begin with.
There's
and
no filling.
there's no filling of the venous aneurysm or the venous or the varix at this point. So I think we're done. Good technique just to keep in mind when you take catheters out from a radial approach, and we talked about stroke quite a bit today, is to take the catheter out over a wire, not take the catheter out without a wire or a microcatheter. And that's what we're going to do here. And what I'll do is I'll pull it back into the aorta first,
Can we go wide open on the flush as well?
and then send the wire down into the aorta, and then take it out like that very quickly without having to flick the catheter up into the vertebral.